So in this lecture series, we are going to discuss about nasopharyngeal cancer. So nasopharyngeal cancer is a very important topic for undergrad students, and it is one of the most important asked questions. Okay, so nasopharyngeal tumor, it arises from the nasopharynx, but where area, which area in the nasopharynx? You can see I am quoting in this diagram that there is eustachian tube. Suppose let's see here. This is the opening of the pharyngotympanic tube, that is the eustachian tube. Above the eustachian tube, you have this elevation which I am marking with black. That elevation is known as torus tubaris. Just behind that elevation, you have the fossa of Rosenmuller. So in this diagrams, tell me which is fossa of Rosenmuller. Yes, it is at this particular area. It might be an area of 1 or slightly above than 1. Okay, this 3 seems to be the torus tubaris. Okay, so basically it arises from the fossa of Rosenmuller. Now there might be a question, you might be confused with fossa of Rosenmuller and the sphenopalatine foramen. Remember, sphenopalatine foramen, it lies from the posterior part of the middle turbinate, around 1 centimeter behind at the area of nasopharynx. You have your sphenopalatine foramen. Okay, this area is the area of origin of juvenile nasopharyngeal angiofibroma, and you need to be very careful regarding these two questions. Okay, nasopharyngeal cancer, but first of all you just listen to me and then we'll move on to the slides. Okay, nasopharyngeal cancer is divided into 3 stages by WHO. Okay, WHO grade 1, 2, 3. Okay, 3 is the anaplastic variant, 2 is the transitional, and 1 is the well differentiated variant. Now understand it very well that nasopharyngeal cancer is one of the most common cancers in the nasopharynx, but usually it's not that much common as other malignancies in your body. Okay, but if you talk about the nasopharynx, the most common tumor is NPC. How will the patient present with? Number one, you need to always understand with an approach. Then only it's very easy for you to understand the question. Okay. Number one is history. So what will the patient history? So patient is inside your OPD. He complains of nasal bleed. Okay. But as you just go through the patient's body, okay, his race. So we have been taking, like name, age, sex, religion. These are the different parameters, the patient particulars we are taking, isn't it? So here, as you just see the patient is mongoloid type. He is mongoloid type. What does that mean? That means he is a Chinese, maybe a Chinese population, maybe a mongoloid population, Tibetan person, right? And whenever you ask about his food preferences, he says that I really like salted fish. Or I really like the smell of the innocence. That is basically your agarbatti. Okay, the thing that you just light up to worship God. So I just like that smell. So I've been using it so far. I just use that stick. So much. I have a history of smoking. I love to smoke. Whenever there's a tension, I just take one cigarette and then I smoke it. Okay, so there might be such history. Okay, then you have to rule out these things. Okay, next is recent infections or recent infection regarding Epstein-Barr virus. Okay, now remember there are 2 important aspects. One is human papilloma virus, the other one being the Epstein-Barr virus. Okay, so one is the Epstein-Barr virus, the other one is human papilloma virus. Remember, if someone asks you about the human papilloma virus, it is more commonly related to the sinonasal tumor. But if someone asks you about the Epstein-Barr virus, it is more commonly related to your nasopharyngeal cancer. Okay, so you need to be very much clear regarding this. Okay, next. So nasopharyngeal tumor is somewhere here. So how can the patient present with? Do not mug up clinical features. I will tell you the way to remember. It can come to the nasal cavity. Okay, if it comes to the nasal cavity, nasal obstruction, epistaxis, sinusitis, very common. It is at the area of your nasopharynx. So at the area of your nasopharynx, you also have the opening of the eustachian tube. So if that opening of the eustachian tube, the ventilation to the opening of the eustachian tube, if it is hampered, that will lead that will lead to something which is known as otitis media with effusion. But understand that I will show you from this die. Okay, I want some of a fresh pace. Suppose if you take this as a nasopharynx, okay, the adenoids is in the center, okay, but wherever you tell the fossa of Rosenmuller torus tuber, it's lateralized to one particular side, okay. Eustachian tube of one ear, eustachian tube of other ear, isn't it? It's lateralized to the one particular side. You can see in this diagram. So at this area you have your opening of the eustachian tube or any other aspect, any other part of the nasopharynx. But adenoid is a midline structure. So if there is an adenoid hypertrophy, the patient, the child, not the patient, the child presents with a bilateral otitis media with effusion. But if there's a unilateral otitis media with effusion, unilateral OME, the patient will present with hearing loss only from one ear. Okay. What is the complaint? I really have oral fullness at this particular area. I listen less from this area. I'm not able to localize well from this area. It can come with a nasal bleed. Of course, I told you that. What next? What can happen next? Can't it go towards the brain? Towards your skull? Yes, it can. Via? How can it go to the brain? How can it easily go to the brain? Are you telling something wrong? No, it can go to the brain. And how can it go to the brain? Via the sinus of Morgagni. Now, look at this diagram. See here. Not much more clear here also. But you have your superior constrictor. You have your superior constrictor right over here. You have your middle constrictor and you have your inferior constrictor. So all these superior, middle and inferior constrictor, they come and join at the midline raphe. They come and join at the midline raphe, okay? And inside that, you have your longitudinal muscles, which is your stylopharyngeus, the salpingopharyngeus, and where is it in this diagram? I'm just localizing in this diagram. Palatopharyngeus, salpingopharyngeus, palatopharyngeus, and stylopharyngeus are the three longitudinal muscles that you have. And the circular muscles are the superior constrictor, the middle constrictor, and the inferior constrictor. The base of the skull okay, it's not there also. So just understand in this way. If you just look into the base of skull and the sinus, the superior constrictor, there is this area which is known as a sinus of Morgagni. Okay, there's this area which is known as sinus of Morgagni, and from that sinus of Morgagni, the tumor can actually seed to the skull. And in that sinus of Morgagni, you have something which is known as TAALA. I think TAALA. Tala is the mnemonics for the contents of the sinus of Morgagni. Tensor villi palatini, ascending pharyngeal artery, auditory tube, levator villi palatini, and ascending palatine artery. I'm just slightly confused with the contents, but the above one contents is okay. This A, I'm confused. I'll write it in the description. Okay, so this was about the contents of the sinus of Morgagni. So whenever that tumor goes towards the sinus of Morgagni, it can actually involve that structures. Okay, and tensor villi palatini, levator villi palatini are of course the muscles that open your eustachian tube. Okay, that open and close your eustachian tube. That muscles, okay, contraction and relaxation. And of course, whenever they are disturbed, whenever they are having some problem, that will lead to otitis media with effusion. Okay, now let's go to the next thing. Next very important diagram. So you can see that this cross area is actually the area of your nasopharynx. Okay, see, I'm taking so much time to understand, to make you understand clinical features, because do not mug up. If you mug up, you'll forget everything. Okay, just understand it well. You have your foramen lacerum over here and you have foramen oval over here, right? So foramen lacerum and foramen oval. So from the foramen oval towards your eyes, okay, towards the eyes, there goes different nerve, 2, 3, 6 nerves, right? So if that is involved, it might lead to ophthalmoplegia. Suppose if the sixth nerve is involved, from your ophthalmology, you know that the sixth nerve is responsible for, you know that mnemonics SO4 LR6, right? The sixth nerve is responsible for the lateral rectus contraction. So whenever you look at to your right side, from your right eye, okay, right side, from your right eye, the lateral rectus is contracting, right? So that lateral rectus palsy will be there. So you are not able to see to the right side from your right eye if right eye's lateral rectus is basically involved. Okay, the sixth nerve. Okay, and if you talk about the foramen lacerum, 9, 10, 11 cranial nerves may be involved. It might also be 12, 9, 10, 11, 12 cranial nerves. Person may present with hoarseness of voice. 10th cranial nerve supplies the larynx, superior laryngeal nerve and inferior superior laryngeal and the recurrent laryngeal nerve, the branch of the vagus nerve, right? So all these things comes from your laryngeal part. So from your laryngeal part, you have understood, you have studied about the different pulses like RNL palsy, recurrent laryngeal nerve palsy, superior laryngeal nerve palsy, which are the muscles supplied. So I will take that video in the next session. Right now, just understand that if there is a 10th cranial nerve palsy, the vagus nerve palsy, the patient might present with a hoarseness of voice, isn't it? So, and if of course there is ophthalmoplegia, eye problem, the patient may present with lateral rectus palsy, might present with proptosis. Okay, and also there is running of the cervical sympathetic chain, so the patient may present with Horner syndrome. Okay, wide range of presentation. So you can see here, but the major one being the neck swelling. And there is this at the posterior triangle, there's this nodes of Ruvia. Okay, there's the nodes of Ruvia's sign. Okay, sorry, I'm very much sorry. The nodes of Ruvia are actually seen in the retropharyngeal space. Okay, I often get confused. I actually remembered in this way that nodes of Ruvia was there, that's known as the space of Gillette, the retropharyngeal space, right? And from that Ruvia, I actually correlated that this Ruvia is there, which is known as the neck mass, right? But I got confused right now, so please don't get confused. Okay, the Ruvia sign is actually the swelling at the posterior, the swelling at your posterior triangle, that is known as the Ruvia sign. Okay, and of course nasal symptoms like epistaxis, nasal block and nasal discharge is very, very important. I told you about the otologic signs, the conductive hearing loss and the tinnitus. Patient might present with oral fullness, tinnitus, conductive hearing loss. You might be suspecting whether it is Meniere's or not. Meniere's will come with nasal bleed. Like if the presentation is simply over the ear, you might be thinking whether that's Meniere's, but there's no history of vertigo. You need vertigo, like Tullio's phenomena, Tumarkin crisis, right? You have a lot of things to say that Meniere's disease, and it comes in triad, like first come this, then come this. Okay, we'll talk about this wherever we talk about Meniere's. Okay, now ophthalmologic symptoms like diplopia, ophthalmoplegia, involvement of the 3, 4 and 6 cranial nerves. I already told you this one, right? Proptosis may be there. Jugular foramen syndrome, I told you that there is this foramen which is known as foramen lacerum, and there is a jugular foramen also. Okay, foramen lacerum, jugular foramen also. So jugular foramen, 9, 10, 11 cranial nerves may be involved, and Horner syndrome. If the sympathetic chain is involved, then that might lead to Horner syndrome. Okay, very good. Now, there's something which is known as a Trotter's triad. Please understand this well. NPC is the mnemonics to understand this. Neuralgia, palatal paralysis and conductive hearing loss. Okay, neuralgia, palatal paralysis and conductive hearing loss. Okay, because of the eustachian tube block. So that's the mnemonics. So ipsilateral palatal paralysis. So why will there be a palatal paralysis? Palatal paralysis because of vagus nerve damage. Okay, and there's a ipsilateral temporoparietal neuralgia. Say temporoparietal neuralgia. There's this temporo word. Remember, trigeminal nerve. Okay, temporoparietal neuralgia over here. You know this, like trigeminal nerve. It has 3 branches, right? Trigeminal 3. One is ophthalmic, other one is maxillary, other one is mandibular. You have understood with this one, V1, V2, V3, right? So at this area, temporoparietal area, at this particular area, there's an involvement and there is the palsy of this trigeminal nerve. Okay, and there might be distance mets to bones and lungs, and so to rule out this, we'll just go for a PET scan. Okay, and there is a skull base involvements. To rule out this, just go for an MRI. Okay, now if it's involving towards your bony canal involvement, the spinal canal involved, the bony canal, not the spinal canal. Okay, sorry, I'm sorry, the bony canal involvement, the foramens involvement, just go for CT scan. Okay, CT scan. So you can look into every CT scan, every aspect. You just slice and see everything, right? All the sections you will see. And CT scan, MRI becomes a very, very important investigation. But Remember, if you really want to investigate whether that's a nasopharyngeal mass or not, you have to go for a direct ophthalmology, direct nasopharyngeal examination. So what you'll do is, first of all, you'll take an indirect nasopharyngeal mirror. How will the indirect nasopharyngeal mirror look like? It is curved at two ends, right? It is curved at two ends, so it's like Z type, so that it doesn't touch your tongue, so that you don't have gag reflex, and you can easily see up. So it's turned up, right? So I don't have diagram for that over here, but okay, so you have an indirect mirror, indirect nasopharyngeal mirror. So you can just look into the indirect nasopharyngeal mirror, and then you can look at the mass of your nasopharynx. Number one can be that. Number two is, you can directly go for a direct laryngoscopic examination, direct nasopharyngeal examination with the help of endoscope. Okay, so you'll insert your endoscope from the nose, and then you'll go to the nasopharynx, and then you'll just look into the behind the choana, where you'll have a nasopharynx. You'll just look at the area whether there is mass or not. Now suppose there is no mass, what will you do? Suppose there is no mass, but the signs and symptoms says that this is a case of NPC. You'll go for a blind biopsy. You'll just go there and you'll take the biopsy. Okay, that's known as a blind biopsy. So it's written, see, this ptosis, adduction palsy, proptosis. Okay, this diagram is taken from Dhingra. So you can see all the concise features of NPC is taken in this one. So nasopharyngeal scope you can do. You can directly go for a diagnostic nasal endoscopy. The tumor mass is seen in the nasopharynx. Common site is the fossa of Rosenmuller, but it does not mean that it will just arise from the fossa of Rosenmuller. It can arise from different other sites also. Okay, but the most common, most common, you should not miss, is fossa of Rosenmuller. Okay, it can arise from the lateral wall of the nasopharynx. Okay, it can arise from other different locations, but do not miss fossa of Rosenmuller. Okay. Now, nasopharyngeal tumor biopsy, you can go for a scene or blind biopsy. Okay, and FNAC of the neck nodes. I already told you that there is a Rovius sign. Okay, enlargement of the lymph node at your neck. You can go for an FNAC. CT scan head and neck can be done to understand the tumor extent, the skull base erosion, and cervical lymph node metastasis. So CT scan can be done to know the bony involvement, to know the bony invasion, right? But if you want to understand about the intracranial extension, I already told you that you have to go for an MRI. Okay, I already told you. Okay, and PET scan is usually done for your metastasis. If there's a history of bone pain, maybe liver enzymes will be raised, and on US you see that there's a mass on the liver, suspected tumor, question mark. If you're sent by radiology, just go for a PET scan. Okay, so understand that where the tumor has metastasized. Moreover, I also don't know a lot of things about this one because I'm just a fourth year student right now, right? But as you go on studying, you'll understand this well. So just go for PET scan if you want to rule out metastasis. Serological markers, of course you have to check for serological markers against Epstein-Barr virus. So immunofluorescence for IgA antibodies to viral capsid antigen, IgG antibodies to early antigen, and antibody dependent cellular cytotoxicity assay. Okay, nasopharyngoscopy, you can go for direct nasopharyngoscopy or indirect. Usually prefer direct. Okay, now you can see the different diagrams. There's a CT scan. Okay, we just go through the CT scan and the PET scan. Okay, now let's come to the TNM staging. Remember, TNM staging sometimes asked, and it is different. Okay, understand. Sorry, T1, T2, T3, T4. Very easy, very easy to understand. Okay, just understand. T1 means it is confined to the nasopharynx. T1 means nasopharynx. Okay, T2 means, for this 2, just make it ulta, or make it opposite. S. It looks like an S, right? So involvement of the soft tissues. T3, remember 3 is 3, right? So you'll remember P and S. So if it's involving the paranasal sinus, it is 3. All others is T4. Okay, finished. Okay, so P and S, paranasal sinus, is actually a hollow cavity in the bony structures, right? So bony structures plus PNS involvement, it is T3. Soft tissue involvement of the nasopharynx, of the oropharynx, of the parapharyngeal space, all the soft tissue involvement, you label it as T2. Okay, and T4 means intracranial involvement of the orbit, Cranial nerves, infratemporal fossa and hypopharynx involvement, it is all T4. Now N0, N1, N2 and N3. Remember the triangle host triangle, that is known as a supraclavicle triangle. Okay, I will tell you about. See, supraclavicle triangle, see the diagram over here. You have your clavicle and then you have the junction between the end of the neck and the start of your shoulder. Okay, the C is that junction, and then you make a triangle. The supraclavicle triangle is also known as HO host triangle. Okay, so no evidence of regional lymph node, and N1 is unilateral, N2 is bilateral, and N3 means more than 6 centimeters or in the supraclavicular fossa. Okay, N1 is unilateral and N2 is bilateral, but N1 and N2 means the lymph node size is less than 6 centimeter. The lymph node size is less than 6. N0 means no lymph node present. Okay, remember host triangle. 1, 2, 3, 4. 1 means nasopharynx, 2 means soft tissue, 3 means PNS, 4 means all the structures. M0 means no evidence of distance mets. M1 means distance mets is present. Now let's come to the stage 1, stage 2, stage 3, stage 4. N0, N1, N2, N3. T1, T2, T3, T4. M0, 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 M1. See, so simple. 1, 2, 3, 4. T1, T2, T3, T4. N0, N1, N2, N3. M0, M0, M0 and M1 in that pattern. Okay, it's very easy. Please, NPC question, and there is how do you manage this case? Write TNM. You'll get very good marks. Even if you don't know much more, N0, N1, N2. N2 more than 6 centimeter, N1 less than 6 centimeter. N1 unilateral or bilateral. N0 no lymph node present. M1, M0 no mets, M1 mets. T1, T2, T3, T4. T2 soft tissue, T3 PNS, T4 all the other intracranial structures, orbit structures, ophthalmic structures. T1 means confined to nasopharynx. Finish. So easy. Differential diagnosis: juvenile angiofibroma, rhabdomyosarcoma, and lymphoma, as I already discussed. Okay. I haven't discussed some of the first slides. I'll just go through these first slides before talking about the treatment. Okay. I already told you HLA gene, HLA assigned to A2 and B assigned to Epstein-Barr virus, environmental exposure. I told you environmental exposure, and remember that the gross feature may be there might be a proliferative, ulcerative, and infiltrative type. Okay, and remember that NPC has a bimodal age distribution. It might be seen in children or it might be seen in adults, but most commonly it is seen in adults. Okay, it's a tumor of the adult population. Now let's come to the treatment of NPC. So how will you treat the patient of NPC? What do you think? So if I have to treat the patient of NPC, will I go for surgery? Surgery first modality? No. The first modality is radiation. So you'll just go for a radiation therapy. You'll go for radiotherapy. So what you'll do is you'll just go for external beam therapy. One is external beam therapy. But whenever you go for external beam therapy, the surrounding structures are also involved. That is why we do not go for external beam therapy. Now we have something which is known as brachytherapy. Brachytherapy means brachytherapy is divided into 3 parts. One is intralesional, other one is interstitial, other one is intracavitary. Okay, intracavitary, other one is interstitial, and other one is high dose. High dose is very, very precise. It just burns the area of your tumor. Okay, so external beam radiotherapy, brachytherapy, chemotherapy, surgery. Now chemotherapy and surgery, it's written at the last. Okay, because we do it at the last only. Okay, and immunotherapy against Epstein-Barr virus, and of course I told you Epstein-Barr virus is very good association with this one, right? So external beam radiation, I already talked about that. Now brachytherapy is divided into 3 types: intracavitary, interstitial, and high dose. You need to remember this. Intracavitary, remember intracavitary has the C letter, right? So remember that it is the radioactive substance, it is placed inside the catheter. So that catheter is a C, remember in that way. Okay, intracavitary, you put that radioactive substance in a catheter. Suppose this is a catheter, you put your radioactive substance in the catheter and then you give it inside the tumor. Okay, intracavitary, radioactive substance source is placed inside the catheter or moons and is inserted into the nasopharynx. Interstitial, radioactive source like radium, iridium, iodine, gold is inserted into the tumor tissue. That is interstitial. Into the tumor tissue it is inserted. Next, high dose, high intensity radiation delivered with precision under computer guidance. So under computer guidance, you'll just precisely, burn that tumor. It's very, very important, very, very good. Okay, this is interstitial. Intercavity means you're putting inside a catheter or a mold. Catheter or a mold. High dose chemotherapy, of course, cisplatin and 5-fluorouracil are given if there is a radiation failure and if it's a palliation in the case of distance meds. So if it's a palliative therapy, you have to go for chemoradiation. Chemo as well as your sometimes surgery is needed. So surgery, what can you do? Surgery. Okay, remember, surgery, you can go for nasopharyngectomy, you can go for cryosurgery, you can go for radical neck dissection because lymph nodes are involved here. So you can go for radical neck dissection. You can go for a palliative debulking, just debulk everything. Okay, in T4 tumor, and maringotomy and grommet insertion in the case if you have a unilateral otitis media with effusion. But that is, like a symptomatic treatment. Okay, the major treatment is the radiotherapy, X-ray beam radiation, or it can be a brachytherapy. Brachytherapy can be high dose, intracavitary or interstitial. Okay, learn in this way. And this is your radical neck dissection. And then what do you have? Your prognosis. So if you talk about the prognosis, stage 1 has 95 to 100, 2 has 60 to 80, 3 has 30 to 60, and 4 has 20 to 30. Overall, the tumor of the nasopharynx, NPC, has a good prognosis. It is not a bad, until and unless there is metastasis. If there's metastasis, any tumor is bad, right? But NPC, it is treated initial stages. If it is found, and it is treated with radiation, so it carries a good prognosis. Okay, so nasopharyngectomy, cryosurgery for residual or recurrent tumor. So if it's a recurrent tumor, then you have to go for chemo and you have to go for surgery. Okay, and palliative debulking for T4 tumor, radical neck dissection for radioresistance lymph node metastasis, right? So I would like just to revise now. So we are at the end of the session. 2 minutes of revision and then we complete our NPC. Okay, number 1, it can involve the intracranial area via the sinus of Morgagni. What are the different foramens located around the nasopharyngeal area? Foramen lacerum, foramen ovale, and the jugular foramen. There's something which is known as jugular foramen syndrome. The jugular foramen syndrome is 9, 10, 11, 12 cranial nerves. And if in case there's a compression of the subaqueous sympathetic chain, that will result in Horner's syndrome. Now, next thing that you need to remember is, suppose a person comes with NPC, it might be towards the nasal cavity, it might be towards the ear. Okay, so different locations may be there, different involvements may be there, which we have